I'm not usually the least scary person on the podium, but I think I've just been up there. I have followed a lot of people, including a sitting congressman, and this is the first time where I've ever sat there and said, damn, that's really, really good. So congratulations to you, sir. There's going to be a little bit of overlap in terms of what we talk about and just in terms of disclosures. I do work with both Exact Sciences and with Medtronic. So my task was to basically reality orient everyone to what does CMS, what does Medicare want from you, at least right now. And this is what it's traditionally been, the three-legged stool, coverage, coding, and then determination of payment amount. This is all changing. The stool is rapidly disappearing. Whether it's ACOs or other risk-sharing models, one of the things that I hear consistently now from clients is that, we thought negotiating with a payer was bad. Trying to convince a physician to do something that takes money out of his or her own pocket is next to impossible. Everybody wants the good old days when they could just come into Medicare and sort of beat on me. Okay, those days are absolutely gone, and it will only get tougher. So what is Medicare? Medicare, for your purposes, is essentially the Social Security Act, the reasonable and necessary standard, which is interestingly written as an exclusion. In other words, if you're not reasonable and necessary, you can't get in the first place. Of course, Congress never did us the courtesy of defining what on earth reasonable and necessary means. So CMS tried a couple of times, and the usual stakeholder plea was, we want transparency and predictability. Bullcrap. Okay? What people want is yes. When transparency and predictability give you a transparent and predictable no, they want you to have all the negotiating, nuanced wiggle room on the planet. So no surprise, 2 attempts at rulemaking, frankly, didn't work. And CMS explored it one more time and decided, frankly, that there was no more traction than there was before. So if you're going to look at items and services, which is the way the law describes technologies, and you're going to review them based on some standard, you have to have something. So what CMS has looked for is essentially clinical utility, adequate evidence to conclude that the item or service improves clinically meaningful health outcomes for the Medicare population. That is not a standard that says it makes the doctor feel better or the physician feels more confident in his or her decision-making. As I used to tell people, we're paying you a lot of money to make the patient feel better, not to make yourself feel better. So the reality is that Medicare simply doesn't have the bandwidth to look at most things. Most decisions get deferred to the local administrative contractors or MACs. There used to be over 150 fiscal intermediaries and Medicare carriers. Now you're down to roughly a dozen of various types. The claims system defaults to payment if the code is not edited for non-payment or suspension. I have done a lot of speaking engagements with FDA, where FDA and CMS are both on the same panel, and often people from other countries will go, well, so CMS has to actually approve everything before it gets paid? No, absolutely not. CMS is absolutely blind to most of what it pays for, which should terrify you as a taxpayer and terrify you as an eventual Medicare beneficiary, because your Part B premium is going to be higher because Medicare is cost blind. The way Medicare pays for things is essentially determined by Congress. They either have gap filling, crosswalking, ASP plus 6, you name it, they have it. So when you actually look at national coverage determinations, CMS only does about 4 or 5 of these a year. How many PMAs come out of FDA in a given year? How many 510Ks come out of FDA in a given year? A heck of a lot more than 4. And if you figure that 4 is not just devices, that's also screening and prevention and things along those lines. CMS actually critically reviews a very, very tiny part of what comes out of FDA, or what, if it's not under FDA purview, is asked to be paid for. This is the national coverage determination process as given to us by Congress. It will run 9 to 12 months unless you're in parallel review, in which case it could run, on a somewhat different time frame. But essentially what happens is Medicare first has to determine that you fit within the legal scope of the benefit. Medicare is not required by law to pay for everything that's good for you. There are many things that are good for you, and I will tell you if you're having a conversation with me for certain things, tell me about your direct-to-consumer strategy, because there is no way Medicare can legally pay for you, even if you have 5 meta-analyses of 30 randomized controlled trials with an absolutely astounding benefit. You simply don't fall within the legal scope of the benefit. So once you're assured that, in fact, it is something that Medicare might legally pay for, you then go through an analysis which is not unlike what anyone else looks for. It's evidence-based medicine 101. The process does include public comment. Some of those public commenters are absolutely brilliant, articulate, and on point. Some of those public commenters sign their public comment as Donald Duck or Mickey Mouse, and they go on to rail about Obamacare, which has absolutely nothing to do with the national coverage determination process. So it's like when someone hijacks your thread if you're online. If you want to talk to Medicare, somebody might hijack your request, and you ought to be mindful of who some of those people might be before you decide to sort of expose yourself to that particular experience. But anyway, by law, it takes about 9 months. CMS then puts out a decision which is effective for claims as of the date of service of that decision itself. And it's all in the Federal Register notice there, and the link is down there if any of you just have absolutely nothing else to do and want to read it all. Here's the standard. The standard is the typical evidence-based paradigm that you will see anywhere. The highest level of evidence is essentially meta-analyses of multi-center randomized, sham-controlled, if necessary, clinical trials. The lowest level of evidence is that commenter who signed his name, Donald Duck. And it really does happen. So here it is, somewhat simplified, and it's a little bit more nuanced for diagnostics. If you have a therapeutic intervention, whatever it is, provide adequate evidence. Evidence is peer-reviewed, published evidence. There is an expectation as a government payer that the public will have access to the pivotal information that CMS used to make a decision. If it's your proprietary information, the public doesn't have that. It could be wonderful. We're going to tell you, come on back when you have it published. That a treatment strategy using the new therapeutic technology, CMS does not have a strict comparative effectiveness paradigm. It's simply a typical patient has some typical experience of care. If we add your whatever to the mix, why and how is the patient actually better off? So we're looking for clinically improved, meaningful health outcomes. So if you tell me the scan is better, but the patient is still bedbound, well, the problem is the patient is bedbound. When you're bedbound, you are socially isolated. You can't feed yourself. You can't prepare your own meals. You can't toilet yourself soon enough. You will have essentially osteoporosis from the lack of physical exercise. You'll have decubitus ulcers, and nothing good happens when you have those things. Lastly, in Medicare beneficiaries, it's nice that you only enrolled people under the age of 50 because you thought that was where your technology would work the best. Well, we are the insurance company for grandma who happens to be 74 years old, typically. So for a diagnostic, the evidence part is the same. The incremental information obtained by the new diagnostic technology changes physician recommendations because, by and large, unless you get a group of gastroenterologists, you know what a Schilling test is. So, the loading dose of B12 may have, helped with your B12 deficiency, but by and large, diagnostic tests in and of themselves aren't particularly beneficial. They may or may not have some harms, especially if they are invasive or if they involve ionizing radiation. But in general, the risks and benefits of diagnostics accrue downstream from physician behaviors. So here's what the problem is. I've sat in endless meetings where FDA gets blamed for the tanking of the American economy. Gee, if it weren't for FDA, our GNP would be better, innovation would be better, every darn thing in the world would be better, and I would have hair and I wouldn't need reading glasses. Here's the issue. You don't have an FDA problem. You don't have a CMS problem. You have a math problem. This is the hemoglobin oxygen association curve, which I really hope most of you in the room remember. The easy questions and the easy clinical trials were done a generation before us. And I've been through enough departments of internal medicine. I went to medical school almost 40 years ago. It was always a bald guy in glasses and a bow tie, and the picture was always in black and white. Okay? Those people had it relatively easy because, frankly, healthcare was so bad. It wasn't terribly difficult to show that you were doing something better. I'll move away from the microphone so we're booming at you. Okay, but you're now on the asymptote of the curve. Current medical care, although it's not perfect, isn't awful. So whether you're putting oxygen in to try to saturate hemoglobin or whether you're pouring the previous speaker's money in to try to demonstrate benefit, it takes a heck of a lot of money to demonstrate a relatively small benefit at this point. And this, I usually use this one for the cardiologist, but ironically it would work for you guys as well. The plumbing paradigm of progress for revascularization. When my very first clinical rotation as a third-year student was surgical oncology, and the second-year surgical resident said, get some gloves, we're going to do a digital disimpaction. And I'm thinking digital, like a computer. And I hand him a pair of gloves, and he looks at me and goes, no, Nimrod, you wear 2 pairs of gloves. So that was my introduction to digital disimpaction. So as I tell the cardiologist, you guys are mired in a plumbing paradigm of cardiac care. You're already pretty good plumbers. It's going to take a lot of energy to prove that you're a slightly better plumber today than you were a year ago. So how hard is it to prove that using, the orange plunger is better than sticking your finger down the can? Okay, not real hard. That's not a long trial. Okay, but there are some for people who understand housing plumbing and its dependency on air pressure, among other things. There are some kinds of plugs where, frankly, moving the air pressure around just frankly blows air up the vent stack in your roof. So you kind of get the auger. You're going to sort of roto-rooter the darn thing. Again, that works pretty well. So the newest one now is a roto-rooter essentially with a power drill on it. So how much better than the blue one does the red one have to be before anybody has any interest in doing that? And if you don't happen to own, you're not the landlord for Fraternity Row, how many plug toilets do you really need to deal with? The event rate's pretty darn small. I loved this article when it came out. It essentially says that early clinical trial results are not necessarily or even not reliably replicated as the evidence base gets more mature. And you can't predict the direction or the magnitude of what this change is going to be. So I actually contacted the lead author because I was like, okay, are you telling me that if someone did a single-arm early feasibility study, that's not repeatable later, or are you telling me something else? He goes, no. I mean, if you have a full-blown RCT, the first RCT is unlikely to be the resting place for the estimates on that particular technology. So these are the things that Medicare worries about, and frankly, commercial payers worry about as well when you're dealing with clinical trials. You can read them. I'm going to go ahead and move them. This is the first time I've ever been on a podium with someone else who said the words non-inferiority. I stirred up a hornet's nest 4 years ago when I suggested in notice and comment rulemaking that Medicare should give favored status to superiority trials because non-inferiority trials, frankly, I sometimes call them non-informative trials. But because FDA is very dependent on non-inferiority trials, we figured, well, okay, we're sister agencies, will play well in the sandbox. We backed away from that in the final rule, but encouraged folks, if they were going to come to us with a non-inferiority protocol, to specifically in their protocol, in their conversation with us, tell us how they were going to address the known vulnerabilities methodologically of non-inferiority trials. I do think there is a place for non-inferiority trials, but I don't necessarily think it's in things like cancer. How many cancer patients are going to be accepting of a potential 20% decrease in effectiveness of their cancer therapy because somebody in a trial wants to claim they're equivalent when they're in fact not? Patients with lethal diseases chase minute deltas in effectiveness. They will take on all sorts of burdens. So who wants to throw that away on a non-inferiority delta? Okay? I do think there are some places, for example, back pain. If you had a non-invasive procedure that would give you 80% of the benefit of a more invasive procedure, and the patient was willing to say, you know, after being informed of everything, I'm willing to still have back pain a couple days a week if it means I don't need to be operated on, fine, go for it. But for something serious, it's hard to get enthusiastic about non-inferiority. Don't do any of these things. Do not exclude enrollment of subjects greater than age 65 unless the disease is only found in younger patients. An example of this, lumbar artificial disc replacement, both Charité and ProDisc in their pivotal trials excluded patients over the age of 60 and excluded patients with osteoporosis. Sounds like they excluded Medicare beneficiaries. Do not exclude adequate numbers of women. The only time Medicare has more men than women is in the early disabled population before 65. My personal feeling, I haven't studied it, is that young men are simply more likely to do the sorts of things that give you permanent disability. That's simply sort of behavior. Do not exclude patients with comorbidities commonly found, you know, diabetes, heart failure, et cetera, et cetera. And don't tell different stories to FDA and CMS. We, and I still say we out of habit, have a mutual memorandum of understanding that allows us to share information whether you want to or not. So do not tell your mom you're going to the library and tell your father you're going to church when you are really going to Cancun with your buddies. Okay, someone is going to find out. If you wanted all of this in another form, Tamara Syrick-Jensen, who succeeded me as the director of coverage, she and I co-authored this a few years ago for the regenerative medicine groups, because they at the time were saying, how do we avoid being like Provenge? Tell us how to do things smoother. So they invited us to write a commentary, so we went ahead and did it. I'm going to close with some comments on diagnostic testing. We do have some regulations on diagnostic testing. It does have to be ordered by the patient's treating physician who uses the test result. So the usual question that comes up is, how would a reasonable physician acting in a manner consistent with evidence actually use the test result? And there's 3 diagrams here. And for anybody who's just like for whatever reason really curious about it, colorectal cancer screening fits down here. Special statutory conditions apply. Okay, and I'm not going to go through all of this, simply to say that as the law has changed, CMS has had different authorities and arguably different standards to deal with prevention and screening. The U.S. Preventive Services Task Force A and B recommendations, while they are binding on commercial payers, are not binding on CMS. CMS actually has a different authority dating from 2008 in order to deal with those things. Again, a couple of more of these. I'm not going to go through them. They're in the slides. You can walk through them yourself. So I'm going to close with a couple of things. Okay, if you have a diagnostic test for CMS absolutely is going to ask you for evidence of clinical utility. In a perfect world, you would have direct evidence. You'd have a clinical trial that goes from the diagnostic test all the way to outcomes. We recognize that doesn't always happen. If you can articulate a chain of logic based on what is known on the therapeutic side and what you're adding on the diagnostic side, if you can support that with evidence, you will generally get a reasonably enthusiastic reception from CMS. But here's what it comes down to. That's fine, you have a test, that's fine, it's accurate. This is the same lock most of us had in high school. If you only need 3 numbers to open the lock, why would it be reasonable or necessary to buy a 4th or 5th number? Not only is that an additional expense, but it increases the likelihood I'm going to put the wrong 3 numbers in if I now have 5 to choose from. So here's an example of that in terms of what we want and what we often get. In 2009, we did a national coverage determination on pharmacogenomic testing to predict response to warfarin. There was 0 concern that the test was not accurate. Okay, absolutely none at all. Absolutely fine on the analytic and clinical validity. But here's the issue. If you read the label for warfarin, it says initiate at a low dose and titrate slowly and carefully if the patient has an adverse pharmacogenomic profile or if it's an elderly patient with comorbidities taking any of the over 130 drugs, herbals, and foodstuffs that are known to interact with warfarin. Well, that second group is the Medicare beneficiary. So if you already have to go low and slow with a beneficiary, why would I want to pay you for genomic evidence? You know, if they have a fine profile, are you going to ignore their age and their comorbidities and say, here, have 10 milligrams of warfarin, take it every day, come back in a month? No, you're probably not. Okay? What's very interesting is that there have been a couple of trials that have been running now for like 6 years, and they still have not reported results. I would think if there were a huge effect size and a huge event rate, those trials would have been done in 2 years. The fact that it lasts this long suggests that there is a benefit, that it is a marginal one at best. There was some talk here earlier in the morning. I've been here all day because I flew in last night. There was some talk earlier in the morning about personalized medicine. The science will be absolutely tough. Is anybody here familiar with the Shiva trial that was reported in Lancet in fall of 2005? Well, the Shiva trial actually looked at molecular targeting. And their conclusion, at least in their trial with their population of people with advanced disease, was that it added no benefit over using the drugs according to their labels. And they were looking at progression-free survival. They were not looking at some esoteric oddball outcome. Okay? Now, clearly there will be more trials. You know, arguably that question is not a closed question, but the first person to actually look at it in a prospective clinical trial said it didn't matter. So I'm going to close with just one final comment, which is promising is the polite way of saying unproven. Okay, whenever anybody tells you they have a promising whatever, demand the proof. Because we will.